Good afternoon, one and all. Trauma can affect the anatomy in such a way that normal standard surgical procedures might not give you the desired results. It may further compromised by lack of resources, and then the innovation comes into play, and innovation is a key to paving surgical advancement and success stories. Herein we present a novel surgical technique and an innovative cost-effective implant for canalicular stenting for its post-traumatic repair. My patient is a 2-year-old child who came with alleged history of injury to the right eye with an iron wire while playing. He presented with pain and bleeding right eye. On examination, his visual acuity with Allen's preschool chart test was normal in both the eyes. An 8 mm partial thickness laceration of upper medial eyelid was noted and with an intact posterior lamina. On closer examination, upper canalicular tear with a retraction of medial part of the canaliculus was also present. We did an urgent intervention. We taken up this kid for GA surgery under general anesthesia. This was our instrument tray. We used a 26 gauge IV cannula, also a 27 gauge metal syringing cannula, McPherson forceps and A2 bicameral suture. This was the initial presentation, top left picture. We did probing first, and then this plastic tube of 26 gauge cannula was inserted over this metal cannula. Then the whole assembly was introduced in the upper torn canalicular lacrimal passage, and once the tube was inserted inside, then we used a McPherson forceps, held the tube there and retracted back the metal cannula. Then we made sure that the distal end of the stent is inside the lacrimal sac. We did the canalicular repair, following which over this particular stent with the help of A2 bicameral suture. Then we did the lid suture in the layers with the same suture. Then we secured this plastic tube with the help of a Prolene suture with the lash line. And then when we checked for the patency, it was patent. This was the immediate post-op result. As clearly seen, the tube is away from the cornea and well in situ. This is post-op 6-week photograph. We removed the tube and sac syringing was also done. It was patent. There is minimal scarring. To discuss, eyelid injuries can be partial or full thickness. This is a significant subset of facial trauma and most commonly occur in children and young adults. Canalicular laceration may or may not be present. However, in cases of medial eyelid injuries, it should always be suspected. Most common causes in children are dog bites or trauma. There are no set repair protocol for canalicular injuries. However, the fundamental principle remains the same, that an urgent and accurate anatomical repair is needed for the functional patency and the better results. The most difficult part of this surgery is how to locate the medial cut end of the canaliculus. The literature says there are various methods: direct evaluation under high magnification, injecting viscoelastic, saline or air bubble through the opposite punctum, or using sympathomimetic drugs. What we did in our case was we used a 26 gauge lacrimal syringing cannula for probing. We followed the natural curvature of the lid and the canalicular system. It led us to easy identification of the distal cut end, which was a whitish circular opening with epithelial lining, and then the innovative stent was inserted. There are few conventional implants available, which are Winnie-Monoka or Ritleg or Cowford canalicular implants. However, the easy availability is questionable. There are few cost-effective innovative implants which are already mentioned in the literature are 20 gauge silicone rod, which has a drawback of auto extrusion. 24 gauge IV cannula can be used in adult population, and a 50 Prolene suture needle was also used. However, it is associated with multiple false facet formation. The principle remains the same, and despite being a zonal hospital in a peripheral setup with limited resources, we wanted to give our child the best of the surgical result to ensure a seamless journey without any ocular morbidity. The challenges in front of us was the pediatric patient, non-availability of conventional implant, how to insert this innovative malleable plastic implant, and limited resources for such a rare and specific injury. The possible shortcoming of our procedure is auto extrusion, loss of implant, and corneal rubbing by the implant. However, none happened in our case. To conclude, the innovation of 26 gauge IV cannula catheter used as a stent for monocanalicular repair, utilizing a 27 gauge metal irrigation cannula as a guiding tool, can be proved as a significant cost effective alternate to the monocanalicular stent. This is also an economical alternate for such lacerations, and the innovation is even more relevant and promising for developing countries under large underprivileged population. The further studies with larger sample size can help prove this technique as an alternate. These are my references. Thank you.
Thank you. What is the biggest disadvantage with this device?
So, the biggest advantage is
Disadvantage.
the easy disadvantage. Sir, it could get auto extruded. Also, it is not very easy to implant this malleable implant inside the torn lacrimal passage, which is already compromised.
Are you prefer in pediatric age group?
Yes, sir. We did it in a pediatric patient, sir. It was 2-year-old
Only
kid.
in all pediatric, but there is some issues like that. The main cost of the surgery is
Yes, sir.
under GA in
Sir.
pediatric. That's why I'm asking to you. Main problem is the main cost is you are highlighting as a low cost. Is
Yes,
it
sir.
easily available?
Yes, sir.
But nowadays, it was an earlier era. Nowadays, everything is easily available in all over India.
True,
because
sir.
some India brands are there. So there is always one criticism over that. Moment we are doing under GA, the cost is roughly around 15,000, including the anesthesia charges minimum. This is
Yes,
the
sir.
norms.
Yes, sir.
So is there any justification? Because if the tube fall or it is displaced, in such cases you are investing 15 to 20,000 extra, but to save, say like 4,500
So
or
we are
2,000.
not saying, we are not commenting that this particular, in case of non-availability of pneumonoca stents at that particular point of time or in a remote location, then as a temporary measure or maybe in the first procedure when you want to give you the best of the surgical result,
Yes.
then if you don't have anything available at that point of time, then you can use these kind of implants.
Yeah. But your answer should be in a government setup.
Sir.
In government setup, GA, OT surgeries, everything is free. Only the stent is not available.
That's correct, sir.
Okay.
So we are in a government setup, hence we
Yes.
had to do it.
Yes,
sir.
yes.
Okay.